Okay, guys, I am going live and I'm just giving me 1 second just to ensure that I am seen. Very good. I am up on YouTube. Let's go over here to LinkedIn. Give me 1 second. Just want to make sure everything is going. I believe that I am going on all. Yes. I am going on all of them. So, gonna start Instagram. Okay, guys. All right. We're up and going now. Okay. So, welcome back. Okay. And again, multi-streaming. So I have Instagram right here, and then I also have YouTube and LinkedIn right here. And like promised, I said that I was coming back to talk about the standards of care. Okay. We've already gone through section 1, 2, and 3. And today we're going to talk about standard 4 and standard 5. Now, these were pretty lengthy. Not too much that I can tell just with me, initially going, that I could see that was a lot different from last year's sections. But do want to kind of go over and give you a little bit of my thoughts. And Instagram, I'm trying to look more on LinkedIn and YouTube. So I'm going to try to do both. So bear with me, okay? And so anywho, let's get right on into it, okay? So section 4 is comprehensive medical evaluation and assessment of comorbidities. Now, if the question is, should I read this one? For one, like I said, I do recommend that you read them all. Okay, but I understand that we are busy and hey, we only have so much time. Okay, but this is one that you should read because it actually, no matter what demographic you see, what population you see, whether you see kids, whether you see older adults, pregnant women, whatever, this is good information across the board. Okay, something else I do want to mention, and just to clarify, I believe it was standard 2. I want to clarify, I got a comment over on YouTube about someone, I guess, didn't quite understand what I was saying when I was talking about community health workers. And at the end of that standard, it really talks about bringing in the community health workers, lay leaders, things like that, people like that can actually help you kind of immerse yourself into the community so people can see you, so people, can trust you. These are people that are on the ground talking for you. These are not necessarily, community health workers are not necessarily people who went to school to be a healthcare professional. So there is a lot of training that has to go with that. And my thought was, because these tend to not be people who are medical professionals, you may get more bang for your buck where you'll be able to delegate that better if you were to hire people who were actual medical professionals, physicians, nurse practitioners, PAs, MAs, front and back office staff, and I made the comment that, if you know that you service a certain type of community, if you can, don't throw away the fact that you should consider also hiring people who are from the community that you service. So for instance, I gave an example of a person that has a clinic on a reservation. She herself was not Native American, but she had staff who were medical professionals that were Native American. And the reason why that was such a good thing, because when people walked in the door, people felt comfortable being able to talk about some of the things that were related to that particular group of people, and that person or people were able to actually go out and educate the staff. And so where my correction, I'm not going to even say it's a correction because I think I talked about this, but let me just clarify this. I understand in real world that we won't be able to hire. I mean, we're outnumbered. You may be a solo practitioner and it's just you. You know what I'm saying? But the take home point is that if you can hire people, that's fine. If you cannot, do yourself a favor and immerse yourself into the population that you serve. So, for instance, if you are a man and you see a lot of women, it would do you good to take courses and classes over how to engage women. If you're a person that sees another race, let's say, I'm a Black person, maybe I go and I'm in an area where I see a lot of Latino influenced people. I need to make it my business to know about the culture that I talk about. Now, if you can hire people, I'm not saying that you shouldn't talk to people, you shouldn't be a part. I'm not saying that at all. I think it's all a part of the whole collective. We should be doing everything to engage our patients. Our clinic should look like a rainbow coalition. People should feel welcomed when they come in, and they should see themselves in there. So if you have multiple cultures, if you can, try to have multiple cultures that work there. That's all I was saying. And if you cannot, then you should try to know as much as you possibly can about the demographic that you see. That goes across the board. Whether you see someone that's part of the homeless community, you should be trying to get out there and understand what are their pain points. That is a part of being a service to people. And that's what I meant. So if the person who sent me the message is listening, that's what I meant. It wasn't to be exclusive. Clearly, I'm trying to talk about being all inclusive here and all the different ways that we can be inclusive. So anyways, let's get into it. I've spent enough time there. So like I said, this is comprehensive medical evaluation and assessment of comorbidities. And out the gate, immediately we can see a theme: patient-centered collaborative care. Okay. And so this is something that I think we can all say the ADA is wanting us to really take this point home. Everything that we do should be keeping the patient at the center. It is not about what you think is right with the patient. Even with the guidelines and the standards, yes, this is what you can use as your guide, but that is just what it is. It's a guide, and each person has a unique experience. So you have to look at the person to person. It's not anything that's blanket. You have to be very collaborative with your patient. And it really does lay out like what that looks like. Your communication style should be very strength-based with your language, very encouraging, active listening, and really assessing the patient's, eliciting the patient's preferences, their beliefs, assessing their literacy and numeracy, which we talked about a couple of days ago, and then the potential barriers that a person may have. One of those ways that you can do that is really assessing the SDOH, which we spoke about the last couple of times as well. And so that's a take-home point, and you're going to see that theme throughout. So that is a thing. This is not a new thing for this year, but I do want to mention that it does list out what are the goals of treatment when it comes to diabetes. And this is something that I just feel like it's good that I mention it, because I want everybody to understand what we're doing here. Okay, so your goal of treatment is not necessarily I'm trying to get them at an A1C that's under blah, 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 blah. No, the overall goals for treatment for diabetes, as they have it outlined here, are to prevent and delay complications and optimize quality of life. Now, I will also say this. Something that is a mind shift that we're all going to have to really accept is that some patients may not be able to get under a 7. For whatever reason, there's a lot of things that may be going on with them, comorbidities. They may be at more higher risk for hypoglycemia, which we'll be talking about later on in our talks. But as you see here, the goal is not get them to this number or they should be doing this. No, the goal here is to prevent and delay complications and optimize their quality of life. And that is something that can be applied to everyone, though everyone's different. That's what we're doing here. So I like that. Something else that I want to really point out, again, they're really talking about language a lot. And the language, it says here, I love this right here. Language has a strong impact on perceptions and behavior. The use of empowering language in diabetes care and education can help to inform and motivate people. Yet language that shames and judges may undermine the effort. So we really need to be very mindful on not only our verbal communication, but also our nonverbal communication, making sure that we're not being dismissive. I will talk about that a little later in the coming weeks, but just making sure that, like, as it said earlier, it's strength-based. What are they doing right? You know, think about it. If you're always being told what you're doing wrong, is that encouraging? It's not. It's not encouraging. So you want to, even if it's just the fact, I've even had patients where, you know, the fact that you are taking your medications every day, the fact that you are, you know, taking your blood sugars every day, and you brought this into me. Thank you. I really appreciate that. Because, like, we can really overlook that thing. Like, that's just something that they do. No, that's not an easy thing to do for people, and to do it forever. You know, like, they'll be dealing with this diagnosis a lifetime. So, you know, people coming to you, like, you have to cheer them on there. You have to empower them and encourage them. Like, thank you for coming in to even talk to me about this. Because we absolutely know there are people who won't. So you have to acknowledge when they're doing things right. Something that I do want to point out, this is not a new graphic, but this graphic right here is your decision tree for patient-centered glycemic management in type 2 diabetes. It's a very good graphic to look at. Just really giving you, and as you see here, the patient is in the center of the care. So all of this that's going on is all circling around this patient. And as you read these different things, so this is a good graphic to have, right? So let's see. One of the things that I do want to bring up is the comprehensive medical evaluation. Another chart that would be very good for you to keep, just for good references, is this chart that gives you, like, how do we go about, what do we need to screen for with our patients with diabetes. I'm going to show it here too. I don't know if y'all can see that over there, but it tells you what you should do at the initial visit, what you should do at the follow-up visit, and what you should do at the annual visit. And I do want to correct myself. I think I said something about, like, getting a weight. I think I mixed that up with something. You do get a weight every time, every encounter. But you don't get a blood pressure or lipids every encounter, unless, you know, clinical judgment, of course. But per this, you get it at the initial visit, and then you get it annually, the blood pressure. And I think I got that mixed up with the weight. We always get our weight. But you don't always have to tell the person if that's something that's a point of contention for them. You don't have to always tell them about their weight. You can just get it for your own records, because we don't want people to feel shamed for their weight. But this is a really good graphic here, because it tells you everything that you should do, from, like, your history to medications and vaccinations to the social life assessment, physical, what you do in your physical exam, and what labs do you get. So this is really good. It's a great chart for the initial visit, every follow-up visit, and then annual visits. So that's a good one to kind of have near for you. Speaking about vaccinations, this is not new for this year, but it's a recent change within the past few years. Our pneumonia shots. So for the longest, people were giving the Prevnar 13. You have the Pneumovax 23, and then you have the Prevnar 13. Well, couple of years back, basically, it's no longer recommended to give the Prevnar 13 after 65 and older, which was something that people were doing routinely. And what it says here, it's not recommended. No longer routinely recommended for patients over 65 of age because of the declining rates of pneumonia attributed to these strains. So the strain, they're not seeing the strain for that particular vaccine, so it's not recommended. But it is something to consider if the person has is immunocompromised. So things like they're missing a spleen. They no longer have their spleen, advanced kidney disease, cochlear implants, CF leaks, things like that, immunocompromised people. And then there should be a conversation whether or not we should do that or not. But for the average person, that Prevnar 23, not Prevnar, Pneumovax 23. So basically just an overview of what the pneumonia schedule is over the lifespan. 4 doses of the Prevnar 13 by 15 months of age. So these are our little babies. They should be getting a 4-dose series, and then they can catch up between the ages of 2 and 5 with the Prevnar. By the time they hit 6 to 18, we should be giving the Pneumovax 23, 1 dose there, and then 1 dose of the Pneumovax 23 between 19 and 64. And then they get another 1 dose at 65 and older if there is no immunocompromising situation. Now, if they do have that, then you would consider the Prevnar 13, but it also outlines how you should give it as well, because they'll get both basically. And so that's something that I see a lot of people, we're still kind of in that mindset of giving the Prevnar 13. So just to let you all know, has a great chart of like the breakdown of all the vaccines that are recommended for those who have diabetes. A big difference from last year is that there's more about coronavirus in the vaccine. So last year was a little small, it was a little bitty small little paragraph. Now it's like a whole section over like what that vaccine is for, especially for those who have diabetes. And let me see if I can actually kind of read something off to you, because I wanted to point out what they said. Yes, the last statement of the section definitely says the COVID-19 vaccine will likely become a routine part of the annual preventative schedule for people with diabetes. They've already stated that, which I think we all kind of thought that. We're going to be getting the COVID vaccine like we get the flu shot, and so that, just to let you all know about that. And I want to say that's all I really want to cover with section 4. I think that's really all that, not to say there's nothing that's notable, but again, my time coming on here talking with you guys is more to just kind of give you commentary of like any changes, any updates, and just some interesting things that I feel like the general, public of clinicians would want to know. Definitely recommend you go read it for yourself, especially if you have some questions, because it goes really into detail. And so, anywho, that is section 4. All right. So let's get on to section 5. So section 5, this is my place that I love to hang out. And that's because I'm a diabetes care and education specialist. So this is, the name is Facilitating Behavior Change and Well-Being to Improve Health Outcomes. So this is where you're going to get into a lot of your lifestyle modifications, like really what that is. Like really what are your lifestyle modifications and the proper way to educate over that. What diabetes education is, what self-management education is, medical nutrition therapy, what that is, and lots of resources to look into. So as a diabetes care and education specialist, this is the standard that we tend to kind of hang out in. Because we base a lot of our care off of this, but this is something that everybody should base their care off of this. So anyways, so let's get into it. Out the gate, it defines for us what diabetes self-management education and support is. For those who don't know, it's an actual service. It's a billable service. Medical nutrition therapy is a billable service. That is, it's not just the education that you give where we're giving out brochures. It's an actual program. It has standards, and you can have a program in your office or in your community, and it to be recognized, you can be recognized through the ADA or the ADCES, which is the Association for Diabetes Care and Education Specialists. But they have full standards on what is considered diabetes self-management education and support. Now, for Medicare, the term that they use is DSMT, which means training. So it's the same thing, though. Okay. MNT and DSMES are very effective, but it's highly underused. Highly, highly, highly underused. I think a lot of it has to do with there are not a lot of programs, and I think some of it has to do with people don't understand that it's an actual program. Like, you actually send people there, and they're there for weeks. They're there, like, it's something that you refer to, you know. It's not something that you do as you're finishing up your follow-up and, hey, I've done DS. No. There's actual curriculum that goes with this, right? And so that's what it's outlining. It's talking about how effective it is. It's talking about its benefits. It gives you all kinds of research about the evidence that's around it. One of the things that I noticed out the gate, which was different from last year, is that it says digital coaching and digital self-management interventions can be effective methods to deliver diabetes self-management education and support. And I know that they figured that out because of COVID. In my area, there are lots of, well, I'm not going to say lots. There are programs that are 100% virtual. Patients go, and they go from the comfort of their home, on their computer, on their phone. And it does not, here's the thing, this does not even have to be ran by a nurse practitioner. This doesn't have to be. You can train your staff to do this if you have the capacity to do it. But you really just have to be a life coach. And as a life coach, well, a diabetes life coach, not like the ones we see on Instagram and stuff like that. Like, you actually have to go through a training where you're trained on the curriculum, and that's the person who actually can go through and do the actual program. But you can have someone, it can be a nurse, it can be a physician, it can be a pharmacist, but it doesn't have to be. It could be like, I don't know, the girl that does your billing. It really can, if she goes through the training, right? And so, because there's a lot of like business behind it, you need to know how to bill for it. You need to know what your codes are. So it's a whole thing. It's a very whole thing. And so it gives you, let me just define what it gives the definition for. It says, this facilitates the knowledge, decision-making, skills, mastery necessary for optimum diabetes self-care and incorporate the needs, the goals, and life experiences of the person with diabetes. This is where we want our patients to be. Truth of the matter is, our patients will spend more time away from us than they will in our office. And when they come into the office, how much time do they get with us? We literally just see a little snapshot of what's going on with them. So we have to empower them to be able to make good problem solving, to have good problem solving skills, to be able to manage their diagnosis when they're away from us, because truth be told, they'll be away from us the majority of time. So this is what this program does. It literally is it's not for the provider, it's for the patient. So they can be empowered and they can be the person who drives their diagnosis. Now, it says that the overall objectives of DSMES are to support informed decision-making, self-care behaviors, problem solving, and active collaboration with the healthcare team to improve clinical outcomes, status, and well-being in a cost-effective manner. And so typically where you would want to evaluate for the need for this, it gives you 4 times. This is not new. It's the same thing from last year. You definitely want to evaluate, definitely at diagnosis. At diagnosis, you definitely want to get somebody tied in to a DSMES. program annually, and or when a person is not meeting their treatment target. And we talked a little bit about treatment inertia, I think, in the last time I came on here. Basically, we have to be progressive. So you have to look at the patient, you do something. In 3 months, if they come back and they're still not at the target that you set for them, you have to do something else. They want us at all costs to avoid treatment inertia, okay? You got to be progressive in your care because we need to get them to target as soon as possible to be able to prevent these and delay complications. And so then the third time is when there's complicating factors. So this could be health conditions, physical limitations, emotional factors, or basic living needs that develop that influence the self-management. So complicating, like they had a fall and they broke their hip and now they can't get around like they normally do, or they're going to be off their feet for a couple of months. That's a complicating factor. You know what I'm saying? Being that they have diabetes, they're not going to heal the way that someone who doesn't have diabetes has. We know that. You know what I'm saying? And we also are going to have to really talk about nutrition because they're going to need protein to heal. So that's an example of a complicating factor. And then lastly, when transitions in life and care occur. Some of the common ones I can give examples of is like, let's say they have a physician, one of their people on their care team retires and now they have to get a new doctor. You know, they move. Let's say you have a patient that's been living on their own. Now they're living in assisted living. Or let's say, you know, they've had a long condition that they've been in the hospital a while and now they're coming back out. You know, maybe they're going to go and live with their children. They were living by themselves. See, these are transitions in life. You know what I'm saying? So things like that. And it's not even so much with older adults. Even if you're thinking about your children, when a child goes to college, they've been in their parents' home all this time. Now we have to start treating them like an adult because you're now going to college and you're going to need to, that's a transition of life. So that's what they're calling for there. Then it talks a little bit about reimbursement. The reimbursement is there, but you do need to know how to properly code, bill for it. You need to know what it is and understand what it is. Like I said, it's not like after you see a patient, you give them a few brochures and y'all talk about, you know, it's nutritional counseling and now I can bill for DSMES. No, you cannot. It's a whole thing that you're sending people for, and there is a requirement for data to be collected and captured that you'll have to submit as well. And it's a process, you know, to set up a program, you know, especially if you don't have a lot of capacity. It's a process. So it talks about that, but it does say that like they are recommending that third-party payers pay for it because it is effective. It has been proven to work, and you insurances should pay for it. That's what they're saying in reimbursement. It gets into medical nutrition therapy. Now, here's the caveat here that I don't understand. There is no difference between this year and last year unless I overlooked it. But you would think that if you had a patient that you have sent to do DSMES, right, that while they're there, they can get some medical nutrition therapy, because a part of this is you can only bill for like a certain time period. So for instance, like I want to say like, I'm getting them mixed up, but like one of them is like, it's like only 30 minutes at a time or something like that. And so you could think like, okay, maybe they can do 30 minutes of DSMES and then 30 minutes of MNT. You can't bill on the same day. Like, so they have to have two separate encounters. So like they can't go on Monday and get it all done in an hour and a half. No, they actually have to, one has to happen on one day and another has to happen on another day. Now you can write for it in the same prescriptions. Like you can refer on the same, you don't have to write, they don't have to have two separate ones. You can say that, but you just can't, they can't be performed on the same exact day. So that's something I don't really understand. That would definitely help a lot of patients out, but I don't get it, but that is what it is. But it goes into MNT, and MNT, from my understanding, needs to be done by an RD or RDN. a registered dietitian nutritionist, or RD, because what happens in MNT, there's a whole assessment that happens with them. Just like how we come and we see patients, the RD goes in and gets the patient's preferences, gets a good history on them. What do you like to eat? And from their expertise, they're able to sculpt an eating plan that works for the patient. Now, I know for me, when I went through school, we did have a nutrition class, and nutrition was talked about with everything that we talked about, but we did not get into the science of sculpting the macronutrients and stuff, but that's what nutritionists do. And so that is where you would need to leverage, really leverage, that's a part of your care team, is that nutritionist, that dietitian. And so anyways, so basically they're saying here, there is no one size fit all meal plan, which I mentioned that, I think the last time I was on here. And you really can't have that because we all have different preferences in food. You have allergies, you have food intolerances. So to say that everybody should eat this one meal, I mean, really, honestly, does that really make sense? It really doesn't. It really doesn't. And so that's what they're saying. They do have good results for certain diets, like the Mediterranean diet has very good results. Plant-based, vegan diets, yes, but not enough evidence where they can make that blanket statement for everybody that has diabetes. And so that's what they're highlighting here. There is no one size fits all. Something to note about MNT, in and of itself, by itself, if implemented and followed effectively, it can reduce the A1C from 1% to 1.9%. So let's think about that. That's taking somebody from an 8 to a 7 just with MNT. Sometimes even higher than that. That's just as effective as metformin. That's what metformin brings you down, from 1 to 2%. Metformin brings your A1C down that same amount. That's what MNT does by itself. So, and we're not even talking about the physical activity. We're not even talking about all the things that they learned in DSMES. So it's powerful, okay? We need to utilize it more. So it highlights that. It highlighted that last year. And then, of course, it goes into like the individual MNT recommendations, as you see, very lengthy. But it goes through like, the carbs and the proteins and the alcohol intake and sodium and all that. And then over here in the actual part where we read it, they go into it here, not in chart form. So before we get into that, the goals of nutrition therapy for adults with diabetes, definitely want to spend some time talking about this briefly. It gives us 4 goals. Like, what are our actual goals? Just like how we have the goals for diabetes management, these are our nutritional goals for those who have diabetes. It's 4 of them right here. And they say, to promote and support healthful eating habits, emphasizing a variety of nutrient-dense foods in appropriate portion sizes to improve overall health and to achieve and maintain body weight goals, attain individualized glycemic, blood pressure, lipid goals, delay or prevent the complication of diabetes. Number 2, to address individual nutrition needs based on personal and cultural preferences, health literacy, numeracy, access to healthful food, willingness and ability to make behavioral changes and existing barriers to change. That's patient-centered. That's addressing SDOH as well, okay? 3rd, to maintain the pleasure of eating by providing non-judgmental messages about food choices while limiting food choices only when indicated by scientific evidence. So what does that mean? People can eat more than just salads. And we should not be just telling our patients, you should eat more fruits and vegetables. Like, they should get pleasure. It literally says they should get pleasure. We should still maintain pleasure with eating. They recognize that. And then it says to provide an individual with diabetes the practical tools for developing healthy eating patterns rather than focusing on individual macronutrients, micronutrients, or single foods. That's why there is no one size fits all. They want us to continue. So basically, what does that say? To me, that says Making healthier choices. That's what that says. We're going to make healthier choices. Food should still be pleasurable. You should be able to go out and eat with your friends, but you should be able to make good decisions around that. Maybe you don't eat the whole thing of queso and chips. Maybe you take out just a few of them. Maybe if you know you're going out to eat, maybe that all the meals leading up to that, you're making sure that you're getting in your nutrients because you know that your dinner is about to be carb filled, that you're monitoring your blood sugar, so you know where you're at before you go in. All of that is a part of that. So that's that. Talks about the weight loss goals. It has an actual section for weight management. And it says that if a person has prediabetes, the weight loss goal to prevent diabetes is the reduction of their weight by 7 to 10%. So that basically means that if a person is 200 pounds, that they should lose 10% of their weight. What 10% is? What is that? 20 pounds, right? And so that will help drastically to reduce them developing diabetes. Now, if they already have diabetes and they are with overweight and obesity, then the weight loss goal is 5%. Now, you may ask yourself, why is it lower when somebody has diabetes versus prediabetes? Because we're trying to prevent it. There's research, there's lots of studies, there's some landmark trials out there that actually highlighted the effectiveness of the weight loss. But if someone has prediabetes, weight loss is 7 to 10% of their body weight. If they already have diabetes and overweight or obese, it's 5%. And it highlights it here. That's not a difference from last year. Okay. Then it gets into the different macronutrients, your carbs, your proteins, your fat. And what the common theme here, if you want to go into it a little bit more, definitely pull this and read it. But overall, there is no amount. It's individualized. And the best person to be able to individualize that for a patient is the registered dietitian. Because that's what they do. You know what I'm saying? And so it basically goes in and talks about that. It goes into the sodium intake, which, is restricted to less than 2,300 milligrams per day, which I want to say that's the same as the general population. There's no different there. We all should be eating that, taking that in. The alcohol intake for women, we should do, it says, let me read this. For women, no more than 1 drink per day, and for men, no more than 2 drinks per day is recommended. Now, what constitutes a drink? 12-ounce beer, that's a drink. 5 ounces of a glass of wine, or a 1.5 ounce of a distilled spirit. So that is what is considered a drink. That's your thing, okay? And so anything more than that, so let's say you do 2 glasses of wine, like you do 10 ounces, a big old glass, that's going to be considered two drinks. You know what I'm saying? And so on and such. So so yeah, I was going to say something, but I lost my train of thought. So it talks about that, goes into what physical activity is, what it is outlined, and there are recommendations for children, for adults, for older adults. And basically, they're saying that for children and adolescents with type 1 and type 2, they should get a minimum of 60 minutes a day of vigorous activity. And then also, I think 3 times a week, does it say that 3 times a week, they should also get bone strengthening activities. Most adults should engage in 150 minutes of exercise a week. And what I tell people is you can break it up over the week. It could be 30 minutes over 5 days. It could be a couple, whatever you like to do. So you don't feel like you're having 150 minutes. No, that's over 7 days, And so that's that. Also, they say to spread it out over 3 weeks a day, making sure that there's no more than 2 consecutive days in between there. I know that after, I want to say 48 hours. So here's the thing about physical activity. It increases the sensitivity to insulin. Our muscles are able to utilize insulin better. So blood sugars tend to be better when you are exercising, but that effect wears off after like 48 hours. So that is the reason why you wouldn't want to have more than 2 days in between. You want it just to be kind of like a constant thing. So exercise increases our insulin sensitivity, and so you want to keep that effect going. And so they talk about that. They also say, which is new, wasn't listed last year, but to break up any sedentary time. We should not sit more than 30 minutes of a day. If you got an Apple Watch, it definitely tells you when to stand up. But they make a note of that. There should be some flexibility training and balance for older adults. I mean, we can think because they're at risk for falls. So you want to make sure that you're getting them into things like yoga and Tai Chi and things that will help with their balance and strengthening. That's what they recommend. And then, yeah, we talked about that. So that's pretty much an overview of the physical activity. And let me see if there's anything else that I want to mention. Something that I didn't mention with protein, that they do highlight that it's not recommended to like decrease people's like dietary recommendation of protein if they have like kidney disease. Now, granted, in outpatient in primary care, you would defer to like a nephrologist with this. But it's saying that I can actually read the statement for you here, but you shouldn't. They're basically saying they don't see a huge benefit for decreasing the protein. Yes, here it is. It says historically low protein eating plans were advised for individuals with diabetic kidney disease with albuminuria and or reduced GFR. However, new evidence does not suggest that people with DKD need to restrict protein to less than the generally recommended protein intake. Reducing the amount of dietary protein below the recommended daily allowance, which is 0.8 grams per kilo, is not recommended because it does not alter the glycemic measures, cardiovascular measures, risk measures, or the rate at which the GFR declines and may increase risk for malnutrition. So that is something that you may start seeing specialists. You might have noticed that already, that there's not a decrease in protein, or you may see people still practicing that. But that's what the ADA says. Based on the evidence, they don't really see a big difference. Now, of course, they talk about like smoking cessation. That is for everybody. We know that. That's a no-brainer. But lastly, I do want to talk a little bit about psychosocial issues. Now, on Instagram, I made a post. I had reposted a post from, I can't remember who. But people don't realize how much of psychosocial issues come up from having the diagnosis of diabetes. And it addresses this here. There is a thing called diabetes distress. People are very anxious about having the disease. People do fear it. People do get depressed. People do feel helpless and hopeless. And you have to screen for that. You have to screen for it. Some people, it's just helping them. That's another reason why getting them education helps. Because then now people can fully understand. How many of us have had patients that you tell them that they have diabetes or they're at risk for having diabetes, and the first thing they think about is, I don't want to give myself shots. Well, whoa, you're jumping the gun here. Like, who said anything about insulin, But that is the idea that John Q. Public has, is that if you get diabetes, you're going to get an amputation and you're going to be sticking yourself every day. And it's like, that doesn't have to be the case for everybody. So you have to do a lot of like educating and re-educating. And that's another reason why education is so big, to throw away these misconceptions, but to also like ease people's fears and anxieties. And so it goes through, making sure that you're routinely asking them how they're doing. Something to consider when it comes to any chronic disease, not just with diabetes, is this. People are in this for the long haul. You can anticipate burnout. Wouldn't you? Like every day I have to get up. I have to take my blood sugar. Every day I got to take these pills. Every day I got to go. Every month, every few months I got to do this. We would all get tired. And that may not be the only chronic disease they're dealing with. You see what I'm saying? So we have to anticipate and also accept that there will be times where our patients are going to get tired. And that's okay. We're not going to be judgmental. We're going to encourage them. We're going to be their coach. We're going to root for them. And we have to understand that, because if we were in that same position, we would probably be that way too. Like, there is nothing that anybody can do all the time, every day. Nothing. There's nothing that we can do, you know? And so you have to understand that. And I think we have to take off our provider caps and put on our people cap. Like, we're dealing with people here. Okay. So anywho, let's see here. Definitely talks about that. And then they also address disordered eating. So you can have, and this is, you know, especially we're not just talking about type 2. We're also talking about all forms of diabetes. You know, people, it's a common thing. Not everybody, but it's not an uncommon thing. I'll put it that way. It's not an uncommon thing to see people know that the way that they eat affects their sugar. We know that. Duh. You know what I'm saying? So you can imagine, if people know that they can manipulate their sugars with the way that they eat, that there could be some disordered eating. And so we do need to address that. We do need to think about that, especially when you're dealing with your teens and your adolescents. You know, without diabetes, you already know there's a lot of self-image things going on. Also, you can't put it past adults. You know, people make unnecessary comments to people about their diabetes. I have had people tell me that they've gone to family gatherings and everybody in the room knows that they have diabetes. And when they go get a piece of cake, everybody's like, you shouldn't eat that. That makes people feel bad. You know, like, I can't have a piece of cake. Yeah, you can have a piece of cake, you know, but they're in the world. And so you can only imagine how that can start to breed disordered eating. You can have binge eating, you know, people who just kind of, you know, I've been restricting myself, now I'm about to eat, or they just, you know, we have a lot of, what can I say? We have a lot of issues around food in our country, but just in general, you know, as people. And so definitely suggest looking into that and considering that in your population as well. So guys, that was a bit. Tomorrow, I'm going to really try tomorrow to come on here and do 6 and 7. 6 is about glycemic targets. And 7 is about diabetes technology. I am a fan of diabetes technology. And so I'm going to try to come on here around this time tomorrow, maybe a little earlier. And we're going to talk about that. And if you did not get all of the video, it will be saved on Instagram, but it's also on LinkedIn and YouTube. I'm going live on all 3 platforms because I know everybody does different things. And so I hope you guys enjoy it. Thank you for joining in. And so that's it. I will talk to you guys later. Bye. Alrighty.